tell me about the role of progesterone with ovulations. Let's start there.
Right. So let's talk about ovulation within a 28-day menstrual cycle, even though we know everyone has different length menstrual cycles and is an individual. Just for the sake of, teaching about the menstrual cycle and what ovulation means. If you have a 28-day cycle, the first day of your cycle is the first day of your period, right? And in order to get to the next period, you have to ovulate. And ovulation is the release of an egg from the ovary. And you have a bunch of eggs that get randomly selected to be in play that cycle. And your brain, your pituitary gland in your brain, sends a signal to the ovary that will randomly select one of those eggs to mature over the course of the next 2 weeks if you have that 28-day cycle. And then additional signals from the brain, known as luteinizing hormone, will be sent out to signal the release of the egg from that mature follicle. And once that egg is released, it can be fertilized or it can basically disintegrate and go away. When that egg is released, that follicle that was housing that egg now goes from producing just estrogen in that first 2 weeks of the menstrual cycle to now becoming a progesterone producing factory. And the purpose behind that is basically progesterone is a pregnancy hormone. It is necessary to convert the lining of your uterus to become receptive to receiving that embryo so that it can implant, and it can sustain implantation. It causes a relaxation effect on the uterine muscles, and it can help a pregnancy to continue and flourish. And it will support that process until the placenta takes over at around 7 to 10 weeks. And what's causing that corpus luteum, which is the name of the follicle that's now producing both estrogen and progesterone, what's causing it to produce that progesterone is actually the signal coming from an embryo. So if that egg, once it's ovulated, actually gets fertilized and over the course of a week turns into an embryo and makes its way to the uterus and actually successfully implants, it's going to start sending a signal back to the ovary to say, hey, keep making progesterone. I'm here and I need you. And so the HCG from the pregnancy that has successfully implanted and is hopefully healthy is going back to the ovary, and it's continuing that process of progesterone release. And let's say that it's not a healthy pregnancy, right? Because most unhealthy pregnancies are stemming from the fact that the embryo is abnormal. Not all, but some of them are. That embryo might start to kind of peter out and stop producing the HCG just because it's not capable of it. And that signal dies down. And then the progesterone production drops. So it's always a case of what came first, the chicken or the egg. We need to come up with a better analogy because it's confusing. But a lot of patients will think that their low progesterone levels caused miscarriages when in fact it's more of a symptom.
Right. So it's probably from it not being a healthy pregnancy. And I was reading up on that because, this is not my area of expertise. I learned about it in medical school and in residency. But, the thought, are you thinking that, or people think that either it's because the pregnancy is not healthy, which is not allowing the progesterone, or there's something innately wrong that doesn't allow the body to produce progesterone. But the way it looks, according to most data, is that it's the first, meaning that it's not a healthy pregnancy. And as a result, the progesterone levels are low, which is a key important factor to consider, especially when people start supplementing early threatened miscarriages and those with recurrent pregnancy loss with progesterone. And we'll talk about that in a second. But you mentioned that the placenta starts to take over at 7 to 10 weeks. So the first scenario I want to bring up is what if, because we know that the corpus luteum can form a cyst on the ovary and cause an ovarian cyst. That's very common. I see a lot of first trimester ultrasounds, dating ultrasounds with cysts on them, and it's likely from the corpus luteum cyst, but they're causing no issues. Rarely, that cyst might rupture and bleed and cause an issue, and where the cyst has to be removed. And if we think it's a corpus luteum cyst and we're at less than that 10-week window, what do?
We need to then give progesterone because we might be taking away that progesterone producing factory. And they actually have really interesting early experiments in my field where they studied these things on apes, primates, and they actually would go and remove the corpus luteum and prove that, that is required for a pregnancy to persist and be successful.
So just to put this pearl out there, if you are pregnant and you have to have a cyst removed at less than 10 weeks of gestation because it ruptured or it's got big and it torsed, causing ovarian torsion, just remember that if you're less than 10 weeks, that you need to be on some sort of progesterone supplementation until you get past that 10-week window, 10-week mark, and then the placenta should take over. Now,
and a lot of times it's not explained to patients. It's
right.
normal to have a cyst. The word cyst scares people,
right.
but all it means is it's a fluid-filled space inside the ovary, right? And in this case, it's a normal part of your biology.
Right, and an overwhelmingly majority of time, even I see these cysts all the time on first trimester ultrasounds. I'm sure you do too. They're not causing any issue, and we just leave them alone.
Right.
You know, we don't do anything about them. Okay. Now let's go into the IVF arena, where we're doing fertility treatments. What role does progesterone play with that?
So in IVF, you know, all those eggs that got recruited to the surface of the ovary that are in play, you're trying to utilize each and every one of them. That's the goal. That's what makes IVF more efficient than just relying on the one egg that matures each month. You're trying to get a bunch of eggs to mature and then trying to fertilize as many as you can and grow as many as you can into embryos. And then that gives you a lot of options, right? So when you're utilizing hormones to try to grow as many of those eggs as possible, it's not the normal situation. It's not your normal biology. And it's especially not your normal biology when we go in to extract each of those eggs using a needle through the vaginal wall into the adjacent ovary and draining the fluid from each of those follicles to pick the mature eggs up. That's not the natural process of ovulation. So there's a lot of evidence that if you were to just leave things alone and say, okay, let's extract the eggs and then put an embryo back a week later, that would not be sufficient, because those follicles that you drained are not going to behave the same way that a normal corpus luteum or corpus luteal cyst would after ovulation. It's not going to produce a sufficient amount of progesterone. And we've observed that, and there's tons of data from the early days of IVF that showed that progesterone supplementation is necessary in the setting of IVF, because it's just not going to be enough on its own, and it's not going to be in a sustained fashion.
So that's why we get to do those lovely progesterone injections in our behinds, right?
Right. And in the case where you're doing a frozen transfer, then it's even more clear, right? Because now it's not like you just had a bunch of eggs extracted. Nothing is happening. You're not ovulating on your own. So we're mimicking as if you did ovulate. And so progesterone is extra crucial in that scenario.
And the progesterone injections in that situation are given up until what gestational age? Routinely.
Usually we'll start to taper them, you know, at the 7.5, 8 week mark, but we'll have you off of everything completely by the 9 week mark.
By 9 weeks. Okay. So that's, you know, I've heard various, there's different protocols, and what we're saying here is what's typically standard, but every patient, I want to make sure we put it out there. Every patient's an individual, and your fertility specialist may deviate a little bit based on their experience or their experience with you. So just because we're saying this here doesn't mean that somebody's wrong, but we're just kind of putting out there what the standard protocols typically are. Just want to make sure we talk about it.
One more thing I want to add, because this comes up a lot, is patients after an embryo transfer will do at-home testing, and they'll automatically assume if a home pregnancy test is negative that it didn't work, and they'll rush to get off of their progesterone injections. And I would caution them to never do that, because some home pregnancy tests are not very sensitive, and you may have a very low positive test, and it's worth following it up to make sure you see what the full potential is there. You could be pregnant, and you don't want to stop those injections prematurely because the pregnancy is depending on it.
So that's why you guys always want to do the blood test.
Yes, exactly.
Yeah, so that's very important that we wait for that. Okay, let's go into, we already talked about the corpus luteum. The role of progesterone in early